I'm joking, come on.
It's pure socialism. It's the British National
He's
Health.
no longer running.
I say this all the time. I mean, if it's the British National Health Service, American stuff. That's what it is. It's run by the government, lock, stock, and barrel, and on the whole provides pretty good health care to its clients. So it's important to acknowledge that, whether one wants to admit it or not. Anyway.
Well, first thing, it's really nice to be with you. It's good to see you, John. Lonnie, thank you. Jennifer, Chris, thank you to all of you. Thanks for coming. Couple things. We shouldn't equate the Tea Party with, or limited government with anti-government. Our Constitution is based upon the idea of a limited, but I think we'd all agree, an effective government. That's always been the tension in the United States history from the time of Ben Franklin, when he first put together what were essentially the predecessors to public libraries. And they're fascinating discussions if you go back and read some of his own writing about why you would start a public library, or say an association that later would lead to a public library. That's always the tension, and that is a very healthy tension. Because we start to think about where we have market failures, or where the market doesn't fit specific individuals who don't participate well in the market. So there's always going to be that. Just as there is in any test, whether an MCAS test, or whether it's any kind of other test, competition is something of a test. And there are those people who do very well at it, there are people who don't do as well at it, and there are some people who frankly fail within the system, if you will. They're still individuals, they still deserve our support, and we still want to support them as Americans. So I don't think the debate has to be one of being no government role here. That's never been the way of the United States, and that's frankly not our perspective. Just a quick thing on Pioneer, to build on what Nani was saying a second ago about what Pioneer's about. We work on 3 issues. It's education, which is our biggest issue. The second one is sort of faster, better, cheaper government, for lack of an artistic or sort of a finer way of saying that. And the third thing is how do we make sure that we have a business climate where people can grow. And this is within this perspective of business growth and prosperity and empowering individuals to make money and succeed. And frankly, love to see them prosperous beyond belief, that we think about healthcare as a cost on business, yes, and that's historically the game changer in American history, in the history of the healthcare market in the United States. We can talk about that in a second. Couple of things. I'm a Series C player. This is a Series A player. I'm not a healthcare expert. Sometimes I kick the ball, it goes off the field. My expertise is in education and in a couple of other areas, regulatory issues, that sort of thing. I usually like to bring the best player, so I'm sorry I could not get Amy Lishko, who's done a series of studies for us, a series of report cards on the Healthcare Reform Act in Massachusetts. She could not make it, so gotta take it. Sorry about that, guys. So let me just start with a couple of things, just introduce a couple of themes. We have never at Pioneer taken a position on the Healthcare Reform Act. I think there's some really intriguing things about the Healthcare Reform Act here in Massachusetts specifically. I'm not going to talk about the ACA because I have different views on that. But there's something really intriguing with the reform, not just politically, and everyone talks about the political handshake that took place. Certainly, that's interesting. That's a different question from policy. The policy interest, I think, for me is state policy, as Nani knows, on the insurance side, on the auto insurance side, but also on the healthcare insurance side. There's a lot of room for experimentation. Traditionally, we've had experimentation across the different states. They've all done different things with very, very different outcomes. We have a high insurance rate and very high costs. Other places, other states have a very high uninsurance rate, like Texas, somewhere in the order of 25% or in that range, and they have much lower healthcare costs. It's not that the two are correlated per se, and I don't believe that. I think there are actually really smart fixes we could make to try and address both issues. The other thing that's really interesting about it is the exchange, the connector, which was to act as something of a clearinghouse for insurance policies. And I think where we got off the road were in 2 specific regards, and I'll get into those in a second. I think John will, this is where we'll probably disagree in some regards. The 2 things I'm going to point out is leadership, not pointing at John, but leadership of the board. The board is largely premised on a large presence from government actors or union interests. This is supposed to actually ensure, there are 2 things that the Healthcare Reform Act is supposed to do. It was supposed to make sure we can insure the indigent to as high a percentage as possibly humanly possible. The second thing was to really deal with small business insurance access. And given the makeup of that board currently, I don't see that level of interest supporting the customers. In part, the customers are businesses, small businesses, and I think we need to change that. The second thing is, I do think that we've restricted the number of plans. We have too many mandates in the plans. We're not trusting people to make choices. And again, we can go back and forth on that. I think John can add a lot more detail as to why they did what they did. And I'm sure he has some very good reasons, but I'm also a great believer that individuals are really smart, and there are lots of other policy areas where we can actually take lessons from that, whether charter schools or other areas we allow people to choose, and actually works really well for them. Couple thoughts on history. If you think about the role, our employer-based system, it really comes out of an IRS decision in the 1940s, at a time when, frankly, wage and price controls were put into place, and we're trying to make it really attractive for folks to head to work, get them out into the workplace. Basically, IRS decision was trying to make health benefits non-taxable. That decision had many, many, many repercussions. It frankly discriminated against small businesses to some extent, the self-employed. If you're an artist, if you are, you have your own consultancy and that sort of thing, it's really hard to get through that. And if you're poor, it's really bad. So in some ways, it was something of a regressive policy in many regards. The other effect of how we've structured both our insurance markets, but also many of our not-for-profit hospitals, providers, is that we don't have anything even close to the kinds of market stimuli, price points. How much does it cost to do something at X hospital versus another hospital? And there's plenty of evidence that some hospitals, for this very same risk-adjusted pool, this very same procedure, are pricing that at 5 times the rate of another hospital, another provider. And normal market doesn't work like that. Okay, my wife is Japanese. Our first child was born in Japan. When I went to the hospital, went to the birthing clinic, we walked in, nervous parents, and the first thing they said to us is, "You're going to be here for 7 days. It's going to cost you $3,500. I said, "It's not what I want to hear right now, but thanks for the information." The point I'm trying to make is, up front, they will say, "This is what it is likely to cost. This is what your likely stay will be. If something changes, we'll let you know immediately." That's an effective price point, even in a place where there's national health insurance, because they believe in price stimuli. You pay 10, 20, 30, or 40% of the procedure in Japan based upon what your wealth status is. So they're still leveraging, even in a national healthcare framework, they're leveraging market stimuli in a way that I think is quite helpful and keeps people sort of invested in their decisions. But also,
you went ahead and decided to have the child anyway.
We did, absolutely. If I had to do it again,
I went to the clinic down the street.
If I had to do it again, I'd do it 10 times over.
Substitute goods are very
well worth the investment. She's going to take care of me when I'm really old. Look, the other thing about the employer-based system is there's not much portability. We can talk about that issue as well in terms of how you think about a market, buying products, and that sort of thing.
Jim, what's portability?
Portability is the ability, if I lose, Pioneer fires me tomorrow, I have no insurance, I go on Cobra for a little bit, then I don't have insurance after that. When you tie it to an individual, that individual makes a decision, the individual is fully invested in the decision. When you're tied to an employer, it's basically, once your term of employment is over, you can be left without insurance. And that's, frankly, we always heard about 47 million people who were uninsured. Half of that number, correct me if I'm wrong on that, John, but half of that number was uninsured for under 4 months, 4 months or under. That's really a portability issue, folks. And that says something about how wrong we got it when we went to an employer-based system. We're a country of individuals. We believe in individual freedoms and responsibilities. We also believe in collective action. I think that's where the government comes in. But I think we really want to go towards, if you think about this in a more theoretical sense, I don't think we're going to undo the employer-based system, so I'm not just trying to talk crazy stuff in front of folks. But I think we should try to make policy changes that get us toward that so we can actually, over time, nudge ourselves back to something like that. Because frankly, from a political philosophy perspective, however much I like Italy, however much I like France, we are not them. I would just ask you also, just think about this. You think about yourself, what you think about health insurance. Do you think tethering your human condition to your employment is correct? I would bet 90% of you in the room would say that's probably not right. I certainly don't believe that it's right. Let me give you one more practical example. I came from manufacturing, so I love when you talk about the insurers as manufacturers. I grew up manufacturing windows and doors. in the construction business for probably the first 7 years of my career. And I had 65 people who worked for us at every level, very low-level manufacturing to really sort of intensive, sort of knowledge-based, computer-based, even back in the 80s, manufacturing. 65 people, I went around trying to think about what health insurance policy I was going to get for my folks. And to be fair to them, of course, I went to the person who probably had the biggest problems, especially if that person was really important to me as a smart, engaged, productive worker. I want to make sure I have that person, I can keep that person, because I'm not on the manufacturing shop doing all the work. He's the, let's say he's the foreman. I've got to keep him. Well, his profile in terms of insurance needs is what I'm going to give to everybody else. So I'm overbuying for lots of the young folks. I'm overbuying for lots of folks in the middle. And essentially, it's, if you think about it, that's what I would call sort of the highest cost common denominator effect. I've got to, this is sort of a BBC term. Can I say this? You got to sex up your, you've got to increase your ask for everybody, and to be fair, according to law, you've got to offer to everybody. That is a big cost. And so when you talk about Jacqueline, amen. But you have to think of all the people who do not have a face because they're not employed, who you're not able to reach, that I was not able to employ because if I had lower costs, man, I could have really kicked butt and I could have beaten a lot of competitors and I would have grown even further. That's the faceless people who are out there who are harmed by high cost insurance and sort of the lock that we have on the lock that's on the system through the employer-based system. So what's the role of markets? And I could give you a full-throated, let's peel back the employer-based system. I'm not going to do that to you. I'd just like to respond to a couple things that John was talking about with the Healthcare Reform Act here in Massachusetts. And the first thing is there are other examples. There is an example in Utah, which we've done some work on. We've spent a lot of time out in Utah. And to some extent, Utah and Massachusetts are the polar opposites. Instead of an independent authority, as we have here, an authority that is, I think, and I don't mean this in the sense of bureaucracy, oh my God, horrible. I think our system is a fairly bureaucratic one. We have 40 individuals who work in a system, about $34 million we spend every year to fund them. They negotiate with the insurers. They market themselves to the individuals, etc. They're very top down. They define what the products are, and they restrict the number of products and the choices that people have. In essence, I think Utah is much more like a private market exchange in the sense that what it's done is it's set up sort of an Orbit-style website where you have something on the order of 60 different plans that are being offered. They, according to what your needs may be, you can specify my specific interests in insuring myself and my family are X, Y, and Z. You can reorder on that web page sort of, what are the ones that meet your needs best. They've worked with the broker community in the sense they had big arguments up front about how much the brokers were making. But at the end of the day, said to them, if you want to participate in the program, you're going to get more people in your market, but you have to knock down your prices. And they've leveraged the market, the market of brokers out there to really educate folks out in the field, rather than trying to do it from in-house. Now, the question is this better than that? Is that better than this? I'd say this. If you take a look at the data, and we've done 5 different report card studies on the Healthcare Reform Act here in Massachusetts. Again, just saying this is we're doing really well on this A. We're doing not so on this B, C, D, F. On different, I don't think we have to give you enough, did we? Gave you A through D in terms of ranks. And the fact of the matter is, I think on the indigent, we've done a tremendous job. Okay, these are largely subsidized products, but we've done a tremendous job. I don't think any of us can look at ourselves in the face and say, look, reducing the number of uninsured is a bad thing. I think they've done a very professional job of managing that. So I think on that, kudos. I think in terms of the products for those folks who are between 150% of the federal poverty rate and 300%, it's been much more of a spotty job. And I think what I'd urge Massachusetts, as well as everybody across the country, as they have to implement these exchanges, is look at both examples. See what's working for small businesses. Take a look at the data and draw from a broader array of experiences than just the experience here in Massachusetts, because ours is a very specific top-down model. And I would just urge you, and well, I'll probably finish with this. I have many more comments, but the conversation's better than me yapping at you. When we did welfare reform in the 1990s, think about the level of experience that we had across the country, the decades of experience that we bolted onto a federal reform. It was 20 plus years, folks, starting in California. Wisconsin did a tremendous amount of work. Other states tried other things that didn't work. And the feds could go and say, here are really 12 different states with long-term experience. And we can draw what the right federal policy might be from all those experiences. I don't care what they say about the ACA, but it is pretty much built on the foundation seen here in Massachusetts. There's not that much in terms of the structure, in terms of the mandates and all the rest. That's very different from what we did here. We can get the nuances, but I think the frame comes from here. That's a real lost opportunity. I think what would have been far better is to say to all the different states, as you do in so many other areas, you're going to get a chance to get many, many more waivers, as the Reagan administration did in the 1980s on so many different fronts. Let them experiment like crazy, and then take your time and develop the right federal policy, the right response, a response based on empirical data, on what works and what doesn't work. I understand the political moment. If we didn't do it now, we'll never get it done. I understand the politics and the handshakes and all that stuff. I understand that's, you know, I'm talking against what was essentially an avalanche or a tidal wave. But it wasn't the right decision, I think, for the country. It's not going to work for places like Texas because they start in a very different place from us. We start out with 8% on insurance, basically, at the start of our effort on the connector, right? Is somewhere in that range? They're 25%. If you take a look at the makeup of the population, our employers have always stuck with their insurance for their employers. It's really sticky. They have almost a moral commitment to stick with their employment, with their insurance for their employees. And you're not going to see that in Texas, folks. This is not going to work for a lot. This will be tremendously expensive. And I do think much more experimentation, empirical data, study, and then formulation of a reasonable, rational policy would be far better. Stop there. I hope that